Good afternoon, everyone,
Welcome.
and thank you so much for the Saudi Society of Bone Marrow Transplant for inviting me for this talk. It's really a privilege to talk about a subject that so close to my heart. And for the sake of time, I will be focusing on sickle cell disease today, where there is really excitement about not only being able to have this patient and the young adults surviving, but thriving with goal to cure. I don't have any financial conflicts to disclose. I do receive research support from two companies that they are doing research related to gene therapy in sickle cell disease. And some of the discussion may use off-label medications. Today, I would hope that we could review together the sickle cell disease biology and natural history, and then focus more about the evolution about bone marrow transplant from matched sibling to currently alternative donors like haplotransplant. And in the third part, we are going to review some of the clinical trial in gene therapy over the last 2 years. So many of you know that sickle cell disease is an inherited hemoglobinopathy that happens really due to a change in one of the bases at uh, the sixth position of the beta globin, and that lead to switching from glutamine to valine, and that by itself it make the cells polymerization harder, and that would make it cause uh, occlusion in the cells, and later we'll explain that the disease is beyond just anemia and it is more like a vascular disease. But what it always strike me that how the impact of this disease is globally. So there is approximately 300,000 children born with this worldwide, and in the United States there is estimate of 100,000 of patients living with a sickle cell, and the impact is specifically with toward the African American here and Hispanic, which make it contributing to health disparity. So we talked about how this change in the hemoglobin B will cause really in the deoxygenated environment polymerization of the hemoglobin S, and it make it have the sickle cell shape as was described by Dr. James Herrick back in 1910. It's been more than 100 years since it was described. And people used to call it anemia, but I really like how we are shifting our thought to call it disease because it goes beyond just causing occlusion and sickling of red blood cells that could cause a small occlusion in the vessels to also important pathophysiology, which is the hemolysis that it is occurring for these red blood cells. Together, this will cause damage to the vasculars. And very, very frequently, we see vasculopathy. A very elegant study by Dr. Michael Dubon looked into evidence of silent stroke, even for patients who may not have any symptomatic weakness neurological, and we see 8 to 10% in many of the teenagers in that. This together infarction, inflammation, vasculopathy make the disease affect literally every organ. You could start from the brain with a stroke, ischemic stroke, to a retinopathy. You could have obviously the anemia, but you could also cause damage to the heart, not just from the iron overload, but also could cause left ventricle diastolic dysfunction, arrhythmia, sudden cardiac death, acute chest syndrome. Recurrently can lead potentially to restrictive lung disease and pulmonary hypertension. In kids, we see splenic sequestration that can be acute and can be urgent, and but also later can lead to a functional hypersplenism and increased risk of infection. And later in life, we see it in the 30 or 40s. Patient develop really nephropathy and kidney failure. Also, sometimes we see liver failure in this patient, in addition to the chronic pain that can be caused by the avascular necrosis. So you could see the picture here clearly. So this is a multi-system disease that can cause mortality. More than 50% of the patients die here in the US by the age of 45. But even worldwide, in Africa, 80% of the kids born with sickle cell disease don't make it to the age of 2. And later, if you could survive, there is so much morbidity associated with it. And This is an excellent review. It recommended to go through the whole milestone of the century during the improvement that has occurred. This is how science builds on. But you could see that it was almost for more than 70 years. Really, there was not so much attention. So we know this was first described in the 1910. In the 1960 was when the genetic a description of the mutation, and Dr. Pauling received the Nobel Prize for that discovery. But some of the clinical improvement didn't happen until the 1980s and 90s when they started the prophylactic penicillin. And very quickly, you could see in the 1984, that's really almost 40 years ago, was the first case of bone marrow transplant that was used for a child with both sickle cell and AML. When they did a transplant, he was cured, obviously, from both of the diseases. And then in the 1996 was really the biggest and the milestone paper by Dr. Walters for that mm, was multi-center study. It was actually an international study that showed and proved the concept that bone marrow transplant can cure sickle cell alone, not with any combined disease. But despite of all of this improvement, I think it is striking to me here, being in the US, that still the median survival, it is almost half of what it is that for normal Americans. So it's close to 80 usually, the life expectancy in the US, and even in the best comprehensive sickle cell, it is around 43 to 45. So this tells me that we need to do more. In pediatrics, close to 98.5% of the kids will survive to adulthood thanks to hydroxyurea, penicillin, and trying to prevent secondary stroke by doing patient on red blood cell exchange protocol. But that's when it goes to adult, it's truly different. And it would be great if we could even cure them to avoid some of these morbidities. So this is the first paper that was the 1984 by Dr. Johnson, and then the milestone paper by Dr. Walters in the New England Journal in the 1996. This together kind of proved that concept, but I want to review some of the recent publications that show that really matched sibling bone marrow transplant should be a standard of care and offered for most of these patients. So the biggest article that published this is by Dr. Gluckman, who looked into the registry both from CIBMTR, Eurocord, and the EBMT, and described the outcomes of really 1,000 patients. That's impressive. Collectively, all together, there's been less than 3,000 since this, but over the last decade, there is an increase in the use of bone marrow transplant. So the median age you will see in that article was 9 years. But the great follow-up was more than 5 years. So we know quite well what are the long-term outcomes. 87 received myeloablative regimen, only 13 were rec. Bone marrow was the dominant source of stem cell with 84, but cord blood was still significant, around 13%, and peripheral blood 7. The percentage of acute GVHD, which is really important, it was only around 14.8, and similar was the chronic GVHD. We tend to use ATG for these patients, and that has helped compared to the earlier studies to decrease the risk of GVHD. Even in matched sibling, unfortunately, still sickle cell is very difficult to engraft, and there was 2.3 graft failure, and that's due to really the inflammatory and the milieu of the bone marrow and that hyperactive marrow. But the mortality in that, again, you could see that it was over a long period, was around 7%, with a 5-year event-free survival around 91.4%, and overall survival close to 93. Those are the graphs and the Kaplan-Meier curve that correlate with this. You can see that the outcomes for children's and for bone marrow tend to be better than the dotted blue, which is the peripheral blood stem cells. So I would truly encourage for this patient to receive bone marrow as a stem cell source, because we should try to do everything to decrease the graft versus host disease. We don't want to replace a disease with other. But I also want to show you another important study by Dr. Francois Bernardin from France that really reported on the French registry data with close to 225 patients. That was more really receiving similar kind of regimen. And you could see that it has cord blood and bone marrow. So they didn't use peripheral blood. And you could see in the graph here on the left that there is a gradual improvement with the period in the 80s and 99 until 99, they were in the blue, and that outcome were not as good with event-free survival in the 80s. But in the most recent era, in the 2000, you could see that the outcome is excellent, 98%. And the overall survival in this whole cohort was really 97 in that recent era to 98. So it's make it really more comfortable to be able to discuss and counsel these families when you are having um, a patient who is referred to you when you have a matched sibling. And there was even a great study that was looking into what's the acceptable risk for families. Because if it's leukemia, we know that the risk of death, we can predict the relapses, we have more life-threatening immediately. When it is non-malignant disease like sickle cell, it's harder because some of this risk are in the future. How could you compare and weigh that risk that it is potentially in the future for death from this complication with the risk of death that could happen in the next 100 days or 1 year? So getting input from family, being shared medical decision is critical. And in the survey of this 69 parents with also an 18 adolescents and 16 were diets with the parents in addition to the kids, that was three buckets of risk. What it is acceptable for transplant-related mortality. And I was shocked, honestly, to learn how much these families and patients will accept even above 5% risk of mortality, close to 72%. And that tells you how much they are struggling with the disease and suffer from it. And they accept risk of GVHD. To them, that was a big deal. It was 50% because they didn't want to just deal with another disease. So that was much lower than even the risk of accepting mortality. Any mortality or go down to 22. So our families always hear the positive thing. They hope that they will do good. But if you tell them death or graft versus disease, that goes lower. And it was important really to hear from them how fertility preservation is critical. So only 56% they will accept the infertility. And that really has, especially for pediatric patients, it make us think twice before we take patients. How could we preserve their fertility, or can we use reduced intensity so they can maintain that option for them in the future? But the biggest challenge on the data I presented, that's for matched sibling. And it may be different a little bit in the Saudi society, but in the United States, it is very difficult to find a matched sibling. So this is data from based on the CIBMTR and NMDP search. The chance of finding a matched sibling for African American or patients with sickle cell is only around percent, and that's similar actually for unrelated because they are this minority is underrepresented in the NMDP. And that's the reason why in the 2008 and after the haplo development, especially with the post-transplant side, there's much excitement and using of half-matched donor where it could make the donor almost available universally. So just very quick overview what haplo means. So it's basically sharing some of that gene. So all of us, we get half of our genome from the father, half from the mother. Here for illustration, they are colored differently. And so if we assume this child number one is a patient with sickle cell who is colored red and blue, you could see this child who has the same or half of the genome or HLA with A24, B52, DR04. It's similar to half of that. Similar is child number three, but child number four is no match. So this increased the chance of truly almost 50% of siblings, but more importantly, father and mother could be the haplo donors because they always will share half of the genome. So that's why we say it is universally available most of the time. And there has been two strategies in bone marrow transplant. One is using the post-transplant cyclophosphamide that mostly now very widely available worldwide. and that it is on the premise that if we give cyclophosphamide at high dose, it will inhibit the aldohydrogenase enzymes, that it is in the effective T cell and basically kill the cells, versus the cells that they are stem cell and naive, or they are not replicated, they will be able to metabolize the cyclophosphamide without being affected. So they can escape that effect of chemotherapy and continue to be able to induce tolerance. And the other method, it is the ex vivo T cell depletion and using magnetic bead. And there's different ways of doing it, either positive selection or negative selection. But I will really focus mostly on the post-transplant side, as that it is more widely available. And the challenge has always been the immunological barriers. How could we overcome? Because haplotransplant has been the holy grail of transplant for so many years. And the ways to try to overcome them, we talked about, especially in sickle cell, that the bone marrow is very hyperactive. There is a lot of inflammation. And one of the important development, in addition to what it was used in John Hopkins protocol for haplotransplant in 2008 study, it's the pre-phase. So we tend to use for 2 to 3 months prior to the transplant, when we give hydroxyurea plus minus azathioprine. But we at the Cleveland Clinic, we stopped using the azathioprine. There has been a couple of cases where we see patients becoming very pancytopenic, and even Dr. De La Fonte from St. Mary in the UK showed and published cases of macrophage activation syndrome, or basically secondary HLH potentially. So that's something we tend to use less. The group in Saudi Arabia and many there in the Asia or India also, they use fludarabine and dexamethasone as a couple of cycles prior to this transplant with a great success. In addition to that, we use the serotherapy, increasing with adding ATG, but also increasing the TBI. And so it's more closer to reduce toxicity and not just reduce intensity. On the T cell depletion, their kind of thought has been mostly with using mega cell dose. That was also being approached for a haplotransplant with a post-size. So there was increase in the cell. This helped to overcome of the rejection rate. There are few studies that they use peripheral blood stem cell or use GCSF stimulated bone marrow, but it was noted increased risk of graft versus host disease when they use that method. And finally was the sirolimus, actually based on some of the NIH data and the non-myeloablative, does promote immune tolerance. So we use, and also it decreased the risk of some of the CNS toxicity. So our graft versus host disease regimen includes sirolimus and MMF. A few other things that are important for transplant physician is to try to avoid major or minor ABO mismatch when you, because in haplotransplant you may have the choices of few donors, and try to choose for that. HLA mismatch doesn't matter. That more important is the ABO match or mismatch. Avoid CMV. There is high risk of reactivation of CMV diseases. So we use letermovir frequently for this patient post-transplant. And donor-specific antibody is the most important things. Because that's also correlated with the rejection, and there are a couple of protocols to decrease that. This is the schema. So you could see the regular fludarabine, Psi, and TBI, but the ATG is added from day -9 to day -7. And in addition to that is the thiotepa. There are a different approach by the John Hopkins where they increase the TBI instead of 200 to be 400. But post-transplant is similar with the cyclophosphamide at day 3, 4, and then MMF and sirolimus after transplant starting at day 5. These are a few of the outcomes. I summarized them for your review. So we published together with Dr. De La Fonte our experience back in 2008. It was only around 18 patients, and the median age was 21. Graft failure was 7%. All the patients survived, but the event-free survival was 93 in this population, with a graft versus host disease incidence in a third of them. The John Hopkins published their group with the increased TBI, and you could see that there was overall survival again of 100, but 8% had graft failure, with third patient has GVHD Dr. Talano and Dr. Fall also similar numbers, 20 to 19. The median age was more the children, 14 to 13. You could see that outcomes were similar in terms of event-free survival in Dr. Fall publication, close to 90%, but with Dr. Talano, that event-free survival went down to 84. So one of the things with all of this data coming, it's how do we truly predict outcome? And I love this article that it is helping us to truly put a score of 1, 2, or 3 for these patients. Similar to many of you who are adult transplanter are familiar with the comorbidity index pre-transplant. So the higher the risk, then the lower the event-free survival. So the best outcome is if you have lower age of 12 and matched sibling, and that's event-free survival range from 92 to 98% in the most recent era. This was based on a big population of close to 1,500 patient. Training model was in 1,000, and then the validation in 355. As they get older, the event-free survival goes lower, and also if we are using unrelated or mismatch or haplodonor, the event-free survival tend to be lower. But as this, what I want to highlight it is there is the ongoing prospective study that it has been done through the BMT CTN. It's called 1507. It's actually already finished accrual for the adult. It is pediatrics arm still open, and hopefully will be closed by the end of this year, and we look forward to see the result of that prospective study. Many people ask me, Dr. Hanna, how do you decide what are indications to take patient to transplant? So usually if a patient in my mind has end organ damage or requiring red blood cell exchange for, if we're starting with kids, for a stroke, or they have evidence of stroke with abnormal cerebral MRI or MRA, those are the biggest two categories because they are at much higher risk for not only another stroke and death, but really long-term cognitive impairment. And even with a transfusion, they are at risk for happening. Recurrent acute chest syndrome and then the veno-occlusive diseases are something that you really have to weigh carefully if they're truly impairing on the function of this kid. As they get to adolescence, we start to see sometimes sickle cell nephropathy or even lung disease. And those two, again, if you have end organ damage, that's make me feel their disease phenotype is severe, and I would recommend taking them to transplant. Adults, it's a little bit easier. I take them for even for pain crisis, that it is more than 3 severe pain crises per year for at least 2 years, despite hydroxyurea. If they have been receiving transfusion frequently, many of these patients, they will end having a lot of antibodies and iron overload. And if they developed any pulmonary hypertension as evidenced by tricuspid valve regurgitation, the earlier you do it, then it's better to prevent long-term problem. So now I'm going to switch gear and talk about gene therapy. So gene therapy, it is basically an autologous transplant, but it is a modified cells. So it is divided into 3 steps. The first step, which honestly, initially I thought it is easy to mobilize, but more and more as we are collecting, we are learning the skills and secrets of sickle cell because they don't mobilize easily. And luckily, now we have plerixafor, which tend to be better, but we need to avoid obviously GCSF for this patient. But we are even with the technical aspect of mobilization, it can be challenging. Then after you collect enough stem cell, that can be 1 cycle, 2 cycles. 2 cycles is the average, but it can be up to 4 cycles. You will tend to send this to a company depending on their techniques. And this is what I call them genetic tools. The cells can go either gene addition through a lentiviral vector or probably gene editing. And the most kind of really now exciting one is using the CRISPR and Cas9, which are really more precise scissors. But there has been also another technique using zinc finger and talon as a way to be able to induce changes in the gene or the basis specifically. And the third part that it will be familiar for many of the nurses, it is similar to what we do for autologous transplant. You give chemotherapy, you wait 2 days here, and then you give the stem cell that have been modified after that. And it's similar kind of post-transplant duration of recovery and complication, including opportunistic infection, veno-occlusive disease. I'm going to spend a few minutes to talk about really what it is the most common nowadays of method, which is uh, how do we, because it's been very challenging technologically to change the hemoglobin S base itself. So what has been found from nature as being really the best model that the persistent hemoglobin F patients do very well and protect them from all the sickle cell complication. So that's why there has been two kind of ways to target that, and that either through the beta globin locus control or LCR, which is the regulatory element for the upstream beta globin. So if you could control this, then you're going to have more fetal hemoglobin, because at birth you tend to have more embryonic and fetal hemoglobin, and that's usually after 6 months it goes away and you will have the regular hemoglobin A and B. So trying to have that active back and turn it on, it would be important. So targeting that LCR, the regulatory upstream, would be important. But the other one, using the persistent hemoglobin F, uh, that was the BCLA11A gene. So if that it is a master regulator, we called it master switch. So when that it is off, like in just in embryo and in just after birth, there is increase in hemoglobin. When it is on, what happens in adulthood, it will actually turn the hemoglobin F down. So through these genetic tools, you could either induce and cut that BCLA11 and take it out, or you could inhibit it. And that's what it is different companies are doing. So you could have persistent hemoglobin F 30, 40%, and that seems to be protected. This is another kind of a way to illustrate the different mechanism. So I said the gene addition are really the two up here, where you are inducing and inserting through a viral. That tend to be lentiviral, seems the safest one, and it's been more than 20 years now used. You could use different hemoglobin A's and B's and be able to have a modified hemoglobin that it is going to be protected. You could have either hemoglobin B insertion or hemoglobin B like, or you could have even gamma hemoglobin, or even have hybrid. Or you could do the editing, which is really the expression of that globin by attacking the BCLA11A, or it's the LCR locus that could through the CRISPR or the Tulane or the zinc finger. So that's where it is now. There is these are the two most common things. There is preclinical, as I mentioned, that they target the base, that A to T at log 6 and the hemoglobin B, but that's still in the preclinical. And all of this method will end to either having a new hemoglobin or basically higher hemoglobin F, and that will have the same anti-sickling effect and property. This is the most kind of close to marketing. You need to remember all the gene therapy are clinical trial. No product has been approved for sickle cell yet. This product of lentiglobin was approved by the EMA for thalassemia, but the company, the Bluebird that produced this, decided to get out of the European market, and they are applying for approval in the US for thalassemia, transfusion dependent thalassemia. But the discussion today is about sickle cell. So it is again the same thing, way collecting stem cell, then giving after this, taking this to the lab, using the lentiglobin, able to induce this new variant of the hemoglobin that it is anti-sickling, give the chemo, then you give the modified cells, etc. And those are some of the data that was presented by the company, and I will show that that the median age was 23, included patients from 12 to 30. They have the highest number of patients enrolled. It's 40 patients. You could see their category that was 31 was for patients adult and 9 kids. It was mostly male with 24. Those are the different genotype here. And mostly it is the 38 where hemoglobin SS. I want to highlight again the number of cycles. On average, it was 2 cycles. The median for stem cell was 10 million. So we really need high number of CD34 because some of these cells you're going to lose in the induction of the vector and later too. So you want at least to be able to infuse 3 to 4 million of the modified cells. So that's the reason why you target at least 10 million in your collection. The engraftment was 19, a little bit because it's a bone marrow and it's using myeloablative regimen with the busulfan. The platelet was around day 28 and 35 days of hospitalization. And this is the characteristic of the new hemoglobin. You could see that it is close to 40% of the total hemoglobin was being by the new hemoglobin from, and we call it hemoglobin 206.
2 more minutes to complete.
Okay. And those are some of the markers of hemolysis that you could see that were decreased. This is the most exciting that was just recently published in 2022, February, that all of this patient, none of them had any veno-occlusive crisis after that. One patient, this is the star here, had some pain, was moderate after that. The other method, it is the CRISPR, which was also just in December of 2020 was published the first 3 patients, and looking forward for seeing their publication. They have finished accrual on their study. So it's exciting to see another technology. And you could see in this 3 patient that they published that the patient have seen significant decrease in their hemoglobin S, and the hemoglobin F, which is the light blue, was anywhere between 37 to like 46 or even higher. And that seems to help prevent. So all the 3 patients that they were average pain crisis 4 to 7, they had no pain crisis afterward, and one of them was close to 2 years follow-up. This is a summary of all the clinical trial that use gene therapy, and you could see that all of them had a good outcome in terms of per the study, but I want to highlight the 2 deaths that happened later for this patient, who is 2 patients on the lentiviral of beta-globin through the lentiviral vector. One was for heart issues and one for blood cancer. There is another patient who developed MDS, is alive, but they are receiving transfusion. But there was analysis done and there was a stop on the studies. They have done for other studies using the same lentiviral, but they have determined that it was not due to the gene therapy, and it was probably due to chemotherapy, potentially, of the conditioning therapy. The study here, you see that the number of patients enrolled and was still remain really low. The one in the CRISPR is now up to, I think, 40, but again, has not been published yet. So to summarize, it is the benefit of bone marrow transplant or gene therapy. It really depends on when the patient age and access. So first and foremost, it is the donor is the biggest difference. In bone marrow transplant, you need that allogenic, that different donor. In gene therapy, no. Chemotherapy, you are using it, although that in gene therapy, you use only busulfan. It's variable in BMT. No rejection in gene therapy. Yes, there is risk for GVHD here. No, and that's the second biggest difference. The TRM or transplant mortality, no one has died directly from gene therapy, but that risk is there potentially due to the busulfan and chemo. The opportunistic risk of infection there, but it is neutropenia and the immune suppression lacking help with the gene therapy. Much longer data for bone marrow transplant versus the gene therapy, it's more new. And the biggest problem, I would think, it is for the developing country, it is access. Transplants is way more affordable and available. We expect gene therapy to be quite expensive, and right now it's only on a research phase. So takeaway, I think that hopefully I can convince you that matched sibling transplant has very good outcome and should be considered standard of care, especially if you have a young child. There is great success and strides has been done in the retrospective case series of donors from haplo match, and we're awaiting the prospective study in CTN. And finally, that the gene therapy is quite exciting. I think it would hopefully be coming to commercialization and availability in the next few years. but we definitely still need longer follow-up needed. And with that, I'm happy to finish and wait any answers. I want to put my contact information and also put a plug that Cleveland Clinic is sponsoring a BMT fellowship for international physicians, and those are the contact for Isam Al Saib, who is available there in Riyadh. And with that, thank you so much for the invitation and happy to answer a question.